So, Dr. Soodhar is a highly accomplished general dentist with advanced training in craniofacial pain, TMJ disorders, orthodontics, and comprehensive dental care. A graduate of the University of Western Ontario, Dr. Soodhar has dedicated his career to expanding the boundaries of dentistry by integrating both science and art in patient care. He's completed over 1,600 hours of advanced continuing education with a special focus on dental implants, orthodontics, cosmetic dentistry, craniofacial pain, and TMJ therapy. Dr. Soodhar is recognized as a diplomate of the American Board of Craniofacial Pain and also a distinguished fellow and fellow of the American Academy of Craniofacial Pain. His practice, Oasis Dental in Milton, Ontario, is known for its innovative, patient-centered approach, offering advanced treatments for TMJ, headaches, and craniofacial pain. Welcome, Dr. Rick.
Thank you very much for inviting me to speak. I enjoy teaching and sharing my knowledge, so hopefully this can help others out, especially with sort of complex cases for TMJ disorders. I know it's an area where a lot of practitioners have sort of trouble in helping manage patients in that aspect. So hopefully this can shed some light. Obviously, this is not a comprehensive lecture to go through all the nitpicky details of what to do and how to do it, but it's just to kind of expose you to kind of like, pique your interest and say, okay, these are different applications of different modalities to be able to help patients in a certain capacity. So we can get started here. Okay, so when we're looking at TMD disorders, right? When you look at the temporomandibular joint, right? I consider it like the Great Imposter. And the reason why I say that is because of the fact that there's a lot of symptoms that will show up that will mimic a lot of other head and neck type of symptoms and even other areas of the body, but it ends up mimicking these different weird, unusual symptoms. And then the TMJ joint is sort of the last thing to look at or not looked at all. The problem is that these patients end up getting stuck in their bodies, so they're almost trapped. And they go around from clinician to clinician and trying to, get answers, but the joint is something that's completely underlooked a lot of the times. So in my practice, usually the patients I see for TMD disorders typically have already seen about me 5, 10, 15, 20 other clinicians ahead of me. And then so when they end up in my office, right, it's kind of a good and bad thing in the sense that if they've already seen everybody else, like a neurologist, ENT, they've seen the acupuncturist, a massage therapist, physio, chiro, like so they've gone through sort of the physical modalities or an osteopath even, right? And they're not getting stability where they say, you know what, I get treated, but then the problem ends up being is that the pain starts to come back after a couple days or a few days, and it kind of comes back and forth, back and forth. So this is kind of common thing that I do hear from a lot of patients. So I just want to kind of go through a few things that we can look at. So we're going to look at it. For myself, I have a family of 3 beautiful daughters and my wife. All my daughters, my eldest one right now is 19. The middle one, I have 2 teens, a 19-year-old and a 15-year-old. And then I have a little one that's not so little anymore, but she's kind of in that preteen era of turning 11 to 12. And then my wife is in the background there, and that's myself. But it's a very interesting household. It keeps us busy with a lot of women in the house, but it's fun and interesting, so they keep me on my toes. So it provide me a lot of empathy in learning how to talk and share. So this is something where I've learned a lot from them in the sense that being able to sit and listen to patients and understanding what the underlying meaning is of what they're trying to say, not just take it at face value. I was already introduced. I had my DDS in 2004 when I graduate. So over the last 21 years or so, I've been, as a general dentist, I've limited my practice is sort of TMD ortho and a lot of jaw development, facial development for kids. So what we do is we treat the adult aspect of it. So when they're on the one end of having the joint issue as an adult, but then the thing is that I saw a lot of these recurring sort of histories of these patients. And then when you start looking back at it, you say, okay, well, what can we do it with them when they're younger as a teen, right? Or even before that as a preteen, or even younger as like a little kid. So, so now what we do is we do a lot of treatment for young kids for jaw development, facial development, airway issues we look at for young kids. Sleep apnea in kids also, it's a very common thing to see. And then in teens and preteens, like headaches, jaw pain, facial pain, jaw locking. And then obviously in adults, jaw pain, facial pain, airway issues also. So all these things kind of go hand in hand. So a lot of practitioners, the issue is that you see a piece of the puzzle, but the thing is that there's a bigger global picture. And I'll kind of show you other things that where we've treated patients where sort of the patient was looked at and tried to be treated, but there's sort of a global aspect or a global approach that we need to take with these type of patients, and have a network of other practitioners that we can rely on to help us out. And I have an amazing circle of practitioners, very gifted practitioners. So something that I don't understand, I make sure I leave my ego at the door and be able to collaborate with other practitioners to be able to find the best result for my patients.
Dr. Rick,
Yes,
are you able to speak a little bit louder or closer to your mic, please?
yes, I can. No problem. Is this better?
Yep, I
Does
think
that
that's
sound
better.
better?
Yep,
Okay, no problem.
thank you.
Not a problem. Sorry, I've been talking all day with my patients, so my voice might be a little bit gone, so I apologize. So these are my contacts through Instagram. You can reach me here, my office number, also office email and website. There's a section on my website where it has a TMJ section that goes through some of the same information that I'll be talking about. It's on the website itself, so you're more than happy to go through that. The website, I actually made it during COVID, so I had about 4 or 5 months off. We weren't working, so I had a lot of time on my hands. So I actually ended up redoing my entire website by myself. So a lot of the photos and videos and testimonials and before and afters, those are all of my patients. So please feel free to go onto our website for that. So a different perspective. The only thing that prevents me from my learning is my education. So as a dentist, right, I graduated, and what happened was is that at that point in my career, I was there as a dentist. So I went through my 4 years of training in dental school. When we were younger as kids, right, my mom actually was hit by a car when we were younger, and I was a teenager around the age of 14. My brother was about 11 years old. She was out to go and getting groceries for us. And then a police officer brought her home, and basically she suffered with a lot of chronic pain, headaches, migraine. She had hip pain, lower back pain, fibromyalgia is what she was diagnosed with. So the thing is that when I graduated dental school and I saw my mom suffer throughout my teens, right? And so you see the effect of it, of these patients that have chronic pain. It's not just the patient that suffers, it's actually their loved ones also, their child, which doesn't have a mother now or a father because they're always in pain, not able to attend to them or be with them or do stuff with them. Or, like the husband or the wife, where now you don't have a wife anymore because she's in pain all the time. So you can't do stuff that you would do with your wife before, like going out, hanging out, going out to dinner. So, I mean, these are things where I saw firsthand how it has an impact not only on the person itself that who's suffering from something of chronic pain, but also how it has an effect on the family also as a unit. So when I graduated dental school, my dad asked me, what make mom better? And at that point, I said, look, I'm trying to put a filling in a tooth and not make it sensitive. And so that was my biggest challenge as a dentist, like, making sure I put a nice filling in and that is it. So I said to my dad, I go, look, I'm just a dentist, but okay, let's figure it out. If you can see behind me here, these bookshelves, I have about 3 of these bookshelves, and I bought all these textbooks on chronic pain, fibromyalgia, TMJ disorders, and read them cover to cover. And led me down to the path of getting my diplomate with the American Board of Craniofacial Pain, my fellow and distinguished fellow. Along the way, I met amazing clinicians that have helped me along, like Dr. Alejandro Loriega, that's put on the McMaster acupuncture program. So I went through his program there. So that was one aspect of from the acupuncture manual therapy that I learned. There's amazing chiropractors that I ended up learning how to do certain muscle techniques and muscle release techniques. So that was amazing to learn from them. Also, then from like a dentist perspective, I had my mentor, Dr. Truitt, who helped me along to learn how to treat TMJ disorders from a jaw perspective and actually changing the bite to be able to treat the joint and get stability for these patients. So I've been very fortunate that way. So that's sort of a story of how I got to this point in my life of why I do what I do today. And I do it to make sure that we can change somebody's life and not only their life, but also help their families too and their kids. So what we're doing is this is a patient of mine, and this is going to be the clinical case that we're going to show. But you can see that this lady, she was hit by a car, and it was a motor vehicle accident. On the right hand side or in the middle of the left video here, you can see that as she's walking with a cane. We were able to provide TMJ treatment, right, with a TMJ splint, ALF treatment, which is jaw expansion, and also acupuncture to be able to provide her some relief to be able to have more stability in the body also. So it's not just the joint that you're looking at. And as a dentist, I'm not claiming to make somebody walk. I am not doing that. But what I'm saying is that if you can stabilize the head and neck region, it can have a good side effect of other parts of the body potentially. And we've all seen this as manual practitioners that, you work on one area of the body, but another area improves also. So this is sort of a global perspective. So the objectives for today's lectures when we do it is to learn how to identify signs and symptoms of TMJ disorders, to understand the basic anatomy, function, and neurology to help explain TMJ disorder symptoms, an introduction to acupuncture for TMD, and also go through some clinical cases at the same time. So when we think of TMJ disorders, what comes to mind when you think of these patients? And obviously, this is not a live course, so we can't go through and ask everybody, but I'd like everybody to just kind of input that in. So at the end of the lecture, we can kind of go through it. But the thing is that most people will just think that it's jaw pain. This is it. Like I have jaw pain, or I can't open my jaw up, right? Maybe some face pain or teeth pain. And that's kind of where it's limited to. But when we actually look at it, you can actually see that when you're looking at these patients, there's symptoms that may look like they're TMJ related. So now when we're looking at them, these symptoms will be like jaw problems, like joint pain, clicking, popping, grating sounds right in here. You're looking at mouth problems also, right? So jaw deviation, so the jaw's not opening properly. Limitation in the opening, right? Trouble opening the mouth, pain in the mouth also. The jaw locking shut so the patient can't open fully or locked open. Okay, and then also teeth problems. You can say, okay, well, that's joint related. But now let's start looking at certain things that you say that, well, it seems unrelated. And this is where I say the TMJ is the great imposter. So you can have ear problems that can show up that are joint related. So ear pain, pressure, clogging of the ears, itchy ears, ringing, sound sensitivity, dizziness, right? Vertigo and extra wax buildup. In the neck, you can get neck pain, stiffness, shoulder and upper back pain, finger and arm numbness and tingling. Throat problems, right? So throat pain, fullness. Patients say, like, I feel like something stuck in my throat, and I feel like I'm constantly clearing my throat. Changes in the voice. So these are common things that you'll see also. Head pain, headaches, tension headaches, migraine symptoms, pain, headaches shooting up the back of the head, the scalp feeling really tender to touch, and also eye problems, eye pain, blurry vision, eye pressure, light sensitivity, and also blurry vision. So there are a lot of neurological connections. So the thing is that when I've gone through this to go back at it, I've went through the literature and I spent a lot of time doing this to find out what the neurological, functional, and anatomical reasons of why these things happen. I don't have the time today to go through and break down everything symptom by symptom, but we'll kind of get a general idea of what's going on. The main thing though is that you have to keep in mind is that you have to make sure you make the appropriate referral first. And this is when patients come in initially with like very bad ocular symptoms or headaches, right? So, and also with a neurologist, migraines, headaches, primary headaches, concussions, motor vehicle whiplash, neck symptoms, gait and movement disorders, ENT, otological ear symptoms, throat symptoms. And then and the reason why I'm saying is this is that sometimes you'll have patients with certain symptoms, and if it's sort of or like first time onset and somebody comes in with blasting headaches and migraines, you want to make sure that like it's not a tumor in the brain, for example, right? Or ear symptoms when you're looking at it. You may think it's jaw pain, for example, and I had a patient that was referred in by 3 oral surgeons, and it actually ended up being squamous cell carcinoma in the jaw. So even though he had jaw pain, it was actually the cancer in the jaw that was referring pain into the ear, and we're the one that picked it up. We had another patient with ocular, like eye pain, for example, and we did actually treat TMJ treatment for him in the past, and he completely stabilized. Came in, and it didn't look right when he came in, like about a year and a half later, like something's not right. He went to the emerge room and ended up getting a CT scan done. They actually found that he had a pituitary gland tumor that was expanding and impressing on the structures inside the brain and the optic nerve, and that's why he was having these symptoms. So you want to make sure that you don't miss sort of the elephant in the room. That's what I'm trying to say. But once they've kind of gone through and they've been kind of processed and they've eliminated from the ENT neurologist, optometrist, ophthalmologist saying, hey, everything's normal, we can't figure it out, then that's when that next step is to step in. But a lot of us obviously will see patients that have already seen a bunch of neurologists, a bunch of ENTs, a bunch of ophthalmologists. So, I mean, they've kind of give you a history that they've already had these different scans and tests all come back negative, but then now they don't know what to do now. So that's where you kind of want to step in. And then, so as a TMJ dentist, you want to look at jaw and teeth problems, because jaw and teeth problems, you want to make sure that they can help out with that. And also any symptoms that are listed in the left-hand side here that you're looking at: eye, head, ear, neck, throat, jaw, mouth, and teeth. Then you want to look at those and say, okay, what can we do also now beyond this? This is a patient that came in that had a disc displacement and a joint problem. So when you're looking at this lady came in and this is what she presented as. And then so now you can see that she comes in with a gait disorder. So she's having trouble walking, right? But also she was having some headaches and jaw problems. We were able to get the bite in a certain position. And with that position with the orthotics, you'll see on the left-hand side of the video, when she takes it out, she completely destabilizes. On the right side of the video, the appliance is still in her mouth and she's walking back and forth. So you can see that there are certain changes that are almost instant that the jaw can have on a global perspective, but from a neurological perspective, it happens. So if you look at this, it seems very strange, but from a neurological perspective, there's an area in the brain called the pontomedullary locomotor strip that allows and initiates locomotion, and the trigeminal nerve also communicates with it. So when you put the splint back in again, it resets the joint and indirectly resets the other center for locomotion. So now when she puts it back in again, you see that she's putting it in, pops it in, she bites into it, resets the joint, and then now she could start walking. And once again, I'm not claiming that I'm going to treat her for her walking or her balance disorder or gait disorder. I'm not doing that. But what I'm saying is that I've treated her joint, and as a great side effect, she had some sort of stability in her balance. So when you're looking at the TMJ, when we're looking at the TMJ anatomy, neuroanatomy, and function, we're going to go through this very briefly. So why do we see all these symptoms? So now this is another example.
His previous dentist had said that his teeth were going to be crowded as they.
So you can see the kid has neck tics, neck pain, and they came with jaw pain.
By wearing the appliance has made that upper.
You get the jaw in the right place, and it stops. So you can see how the TMJ has a connection with the head and neck muscles.
He had a lot of like neck tics and vocal tics, and as you can see, majority of them have subsided. We've brought him up about once, maybe twice a year since he was 6. He's now almost 11. and the progress has been.
So what we did was we did jaw development for the upper jaw and the lower jaw to get the alignment better for him. And that's just to show you guys what happens. Now, when we're looking at the TMJ joint, basically it's a very complex joint, but basically it's the only joint in the body that actually comes out of the socket. So when you're opening and closing, it moves, but there's a disc in between. So you can see that there's the articular eminence, there's the condyle. What the condyle in between is the disc, and that disc acts like a cushion, almost like a toboggan, right? And you're going down the hill, which is the blue, and then your bum is in the green, which is the condyle. So as the joint moves like this, the green part, the yellow disc is moving with it like a toboggan, and it protects it. And then what happens is you have ligaments that hold the disc to the bones. You have lateral ligaments, collateral ones. You also have soft tissue in the back behind in the joint. And then you have a capsule that surrounds at 360 degrees. You also have a muscle attaches into the superior inferior head of the lateral pterygoid. And then you have blood vessels and nerve endings that surround the whole joint 360 degrees. So I'm going to go through this very quickly, but basically from a neurological perspective, when you're looking at it, the trigeminal nerve has three branches: V1 for the eye, V2 for the maxilla, V3 for the mandible. V3 also innervates the TMJ joint for the auricular temporal, masseteric, and deep posterior nerve, which provides the innervation around the joint. So if that disc that sits on top gets displaced or pushed out of place, it's going to compress all those blood vessels and compress the nerves, right? So now when we're looking at it here, right? So you can see that in this dissection that I did, I was very fortunate I was able to do this in Arizona, but you can see here that as you move the jaw open and close, you can see all these, like the fascia, you can see the adipose tissue, you can see the blood vessels, you can see the nerves. So all these tissues, they're all sort of webbed together and they're all connected. So it's not like a typical dissection when you look at it where it's all nice and clean. The body doesn't work that way. When you're looking at it, it's all intertwined. So the blood vessels, the nerve endings, the tendons, the periosteum. So from all the way from the surface of the skin all the way down to the bone, there's a full connection all the way through and through. So it's quite amazing when you start looking at the body this way, that it works as a global system. These are the blood vessels that sit behind the TMJ joint that come behind. So if you get the jaw that gets compressed back, you can compress these blood vessels that also carry sympathetic fibers. So that's your fight and flight response. So a lot of patients with TMJ disorders and facial chronic pain, they have an autonomic dysfunction. And the reason is because the sympathetic fibers in the blood vessels are getting compressed. And if you look at the disc itself in this video here, right? So that here you're looking at the self-centering properties, where it's almost like a hemoglobin or like a tube that you go tubing in on a water slide. So your kind of bum is in the middle, but around the tube you get stuck in it. So the joint is the same thing with the disc. The disc is biconcave shape, so it has almost like a hemoglobin. And then the condyle sits in the middle of it, so it stays center. So that joint stays on top at all times, so that it can protect the joint and allow you to open and close smoothly. So what happens is when you have a joint displacement where the disc is out of place, what will happen is it traps the nerves, the sympathetic, parasympathetic fibers. So you have an autonomic dysfunction possibly, and also the motor fibers and pain fibers of V3. That can cause an arthrokinetic reflex, so that basically if you like tweak your elbow or tweak your shoulder, the muscles around it go into a spasm. So it's not just the joint that's going to hurt, but your shoulder will hurt, your trap will hurt, your deltoid, bicep. All those muscles around it go into spasm to protect that joint. So the TMJ joint is no different. So you have an arthrokinetic reflex that when this joint is out of place, it senses it, and what happens is the muscles go into spasm around it. And what it does is set up myofascial trigger points and causes referral patterns. I don't have a lot of time to go through this, but basically you can see that the site of the problem and the source is different. Where the X is where the site is. So if you palpate the trigger point, for example, here the temporalis, it'll refer pain over the forehead and into the teeth, right? So patients may complain, oh, I have pain in the side of my head here, but it's actually the temporalis that's referring pain. Or a patient may complain, I'm having tooth pain, but it's the temporalis referring in. So masseter, same idea. So the X's are where the source is, or like the trigger points here, but then it's referring pain into other areas. So you have the lateral pterygoid, medial pterygoid, facial muscles, digastrics, SCM, trapezius. Trap and the SCMs are very big muscles that generate these things. So a lot of patients will complain of, I get headaches, and they start kind of like a band around the head, right? Or they say it travels up the side of my head. So this is sort of the SCM and the trap. So the trapezius and the SCM, you'll see that pattern, but it's actually the trapezius that's causing it. And the scalenes also, pain and numbness and tingling in the hands, but the trigger points of the scalenes, treating those will help with that potentially in the hands and arms. Suboccipital and posterior muscles, a lot of pain to the forehead, back of the head, or even like a rubber band feeling around the head. So that's very common. So this patient, for example, we got the joint in the right place. And then so what happens is that this patient has a TMJ issue, and the SCM and the trapezius is causing autonomic dysfunction of visual disturbances. We put the blades in the mouth when a patient bites in and bites on it. What it does is that it decompresses the joint, so the joint can't compress back anymore. So it's not compressing any of the nerves. So the thing is that when the patient takes it out and bites together, it gets compressed and it compresses the nerves. The trigeminal nerve communicates with the neck nerves, with the cervical nerves, and also the accessory nerves. So indirectly, it causes a referral pattern towards them, and that's why you get like trigger points in the SCM and trap. So it sticks are out, palpate.
Coming back a lot quicker.
Bang, but white.
Okay, white. Okay, now when I let go,
Come right back.
okay, put those in now.
So that's the
I just wanna
visual
make sure I'm in the same
disturbance.
spot touching. Close.
So now he puts it in,
Pushing the same spot.
same pressure.
How's that?
There you go.
Maybe a little bit, but not as intense.
Yeah.
So how much less would you say it is?
Scale of 1 to 10.
Hey, the white before was 10, let's say.
I would say it was an 8 out of 10. It went white over, but I could see an outline. Second time was maybe a 2.
2. So you can see a little bit better.
See a lot better.
Okay, pop those in again. Right.
So now this is a trapezius. So I'm palpating for the trigger points here.
Here. Not too bad. Okay, take them out. Right together. Difference.
Yeah, tingling down my arm.
Okay, so when I hold that
So you
there,
can see it said that down.
and right?
Yeah.
Okay, now open big. Pop that in for me. So I haven't moved my hand. Okay, and now. Better? How much better? 50%?
So you can see that the jaw itself has a pretty quick instant reflex with the cervical nerves also. So it's quite amazing that you could do a tongue blade test, right? And that's the spinal accessory nerve for trap and SCM. So with the cervical. And so when you put the tongue blades in, it basically resets the joint in the nervous system, and then it calms it down. So that referral aberrant signal from the joint is no longer sending to the other muscles or the other nerves. So basically the trigeminal nerve communicates with the facial, vagus, hypoglossal, glossopharyngeal, cervical C1 to C6, sympathetic system, parasympathetic system, the reticular formation, so, locus coeruleus, and the emotional pain center. So we're looking at for concentration, alertness, for sleep. So the thing is that trigeminal nerve has a huge impact on the actual nervous system itself. It occupies about 30 to 40% of the somatosensory cortex, which is the homunculus with the big hands and big lips, the diagrams. So it occupies about 30 to 40% of the somatosensory cortex for tactile, thermal, touch, and perception. It occupies about 30 to 40% of the brain for that. And also for the motor cortex, for all movement that we do, 30 to 40% is dedicated to the trigeminal nerve. So the thing is that nerve has a huge impact, and it takes up a lot of real estate inside the brain itself. So 60-second TMJs in, we're going to go through this quickly. We can always do another webinar on this to go through how to actually do it. Tomorrow you get an email on sort of a cheat sheet of how to do the exam. We don't have time to go through it today, but we can always set up another webinar, or even with the new program that we're going to be doing, the course that I'm going to be doing. So we're going to be doing this to teach this. But basically, you're going to stick your pinkies through the external auditory meatus. You're looking for normal motion, which is straight up and down. A deviation, like a drunk driver driving and they veer off and come back to the center lane, veer off to the right or left, but they come back to the center lane. That's a deviation. That's not normal. A deflection is where it's like a drunk driver driving and they crash in to the side and they're off in the ditch. So that's a deflection. That's not a good thing either. And then, so what we do is we want to look for an opening, and what we want to do is we want to see an opening of 50 millimeters, 50. So that's the next thing you want to test for. So the first thing is how they open, straight up and down, or they deviate, right or left, or deflection, they get stuck out. And then the next step is how wide they open. So 50 is what you want to look for, and that's normal. And then the next step from there, now when we're looking at it, is this is sort of general clinical overview. This is on my website also in the TMJ section on the signs and symptoms. But what you're going to see is that normal opening is 50 straight up and down in the green. Yellow means that you have trouble. They'll open more than 50, but they still deviate. So they're going to open and go to the side, open and come back to the middle. But in the red is when you have the disc stuck out of place and it's not going back in place. And then that's when you have a deflection. So with the acupuncture, I'm going to go through briefly, and you guys know this better than I do. But basically what we're using is that we're using neuroreactive sites for acupuncture stimulation. And the musculoskeletal system area is where the somatic, sensory, and motor innervation is particularly rich in innervation. So the neuroreactive sites that I use when I treat my TMD patients is the joint capsule itself, myofascial trigger points, motor points, and ligaments. And those are very, 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 very effective. Typically, the motor points and the myofascial trigger points are the first ones I go after. And typically what we do is looking at the cervical nerves. So you can go for the classical distal points for central neuromodulation. So large intestine 4 is one that you can go after that works really well. And then the reason why it works is from a neurofunctional perspective is that it has the radial nerve, which is C5 to T1, and then with the brachial plexus. And then what happens is that when it comes back into here, it goes into the spinal cord. But in the spinal cord, the trigeminal nucleus, which is like the hub or the highway, you can think of it like a circuit breaker in the back of the neck. So V1, V2, V3 all come back into that circuit breaker. So like you can leave your living room, family room, dining room for your trigeminal nerve. And that all goes into your circuit breaker, which is trigeminal nucleus. It'll go to the brain now and tell you, okay, I have a toothache. So it'll tell you, okay, that's a toothache, V2. Or you hit your lower jaw or lower chin, for example, or the tooth here, and it'll go to the brain, to the trigeminal nucleus, and go to the brain and saying, okay, it's your lower tooth. Also, what happens is you have your facial nerve innervating into that. You have your cervical nerves that'll go into that circuit breaker. So that's like your family room is your facial nerve. Your cervical nerves also will innervate into that. So you could think of that as your like washrooms, for example. Then you have your hypoglossal, glossopharyngeal for your tongue and throat. They go into that area also. You also have your vagus. So the thing is that from a neurological perspective, that trigeminal nerve, that hub or that circuit breaker gets a lot of input from a lot of the nerves from the head and neck area. So this way, what we're doing is we're going after the cervical aspect of it. And then we're trying to input into the trigeminal nucleus. So that's just a rundown. And then also you could do somatic neuromodulation segmentally. And then what you can do is that you can go after the cervical area now from C2 to C7. You can also use neuromodulation along with electrical stimulation also. The accessory nerve, trap, and SCM. So then you can also treat those. You have to be very careful. You have to make sure you know your anatomy. In the trapezius, there's the lung that sits underneath it, so you don't want to cause a pneumothorax. So you have to needle it very carefully. So this is not something for the lighthearted, but you have to be very careful. But the trapezius is a great muscle to work on also. And then the next one is when we're looking at is the SCM. So SCM, same thing. When you're going to be needling the SCM, underneath it is the carotid sheath. So you have to make sure that you're not puncturing into that. So you have to be extremely careful of when you're working in that area. The trigeminal nerve, the auricular temporal nerve, is another area that you can go to. And then so when you're looking at the auricular temporal nerve itself, sorry, go back here. So what we're doing is that we're going just in front of the tragus to needle that, and that works really well. And then the masseter is another area that we can go to also. So when we're looking at the masseter, that's another area that we can needle. And then also when we're looking at it, the facial nerve also passes through there superficially. So you want to just make sure that you can also catch the facial nerve while you're needling also. And then so you can also do electrostimulation, so you can also catch the facial nerve at the same time. The temporalis muscle is another one that we're looking at. So you can needle across there, but it's a very tough muscle to get through because there is the temporalis muscle has a thick fascia that covers it. So needling through it is very tender for the patients. Also, you could do myofascial trigger point wet needling also. So that's another option also. And the lateral pterygoid is another muscle that you can go after also, but it lies very deep inside. So that one you want to be careful of because usually that's the first muscle to go into a spasm for a TMJ patient and the last one to come out of a spasm. So that muscle, you have to be very careful of needling that. You want to be very, very careful with that one there. Now, this is the clinical case we're going to be looking at. So this is the case that we looked at initially right at the beginning. Sorry. Okay. 1 second here. Sorry. So what we did with the patient is that when we're looking at the patient, we wanted to make sure that we were able to help her. So what we were able to do is that we use acupuncture points in the temporalis area, infraorbital area also that worked really well for her, right? So the points that I showed you in the initial part of the section here of the different points, those are the ones that we utilized, and it worked really well for her, and it helped her out a lot. So now when we're looking at also the thing is that not only did we have to use the neurofunctional acupuncture, but we also used appliances for the mouth to help reset the jaw also from a mechanical perspective to be able to provide her stability. So you have to work at it from a from sort of two perspectives. One is the joint itself, but then the other part, which is the structural part of it and the functional part of it to get it more functioning harmoniously. And then the neural part is the acupuncture that works really well for these patients also. That works amazing for them also. And then so the thing is that what we want to also look at is that it also starts when the patients are younger as kids. So you want to make sure that kids, like when they're younger, you can catch these issues when they're little. So tongue ties and lip ties are common to see them. So that's something where you want to catch them when they're little. Also, as they get slightly older, when you start seeing an open bite in the front. So a lot of the times these problems that we see in adults for TMJ disorders are actually subtle signs that you see when they're a lot younger. So in terms of a bad bite, you start seeing stuff like that. So you'll see it ahead of time, and it's almost like a train wreck waiting to happen. And a lot of times you'll see parents that come in with their little one, and you see the parent, and you ask the parent, do you have headaches, migraines, so on and so forth? And their bite is very similar to the child's. And so you can kind of see that that child at some point is going to be going in the same direction as the parent. And then you'll start seeing a lot of facial asymmetries also. So those are common things that you'll see. So what we want to do is we want to also treat that. We have to understand that this complex, you're not just treating the jaw, but you're also treating the upper and lower jaw and how they match with one another. So patients that have thumb sucking habits, even as adults, patients will still thumb suck, or even how they swallow, where they have a tongue thrust where they're thrusting, they don't swallow correctly, that will throw the jaw off too. But it starts when they're younger. So a lot of these things you can screen for in patients when they're a lot younger. And that's the kind of the beauty of this, is looking at patients to be able to catch them while they're young. And if you can do that, they're going to be in a way better place. And then so you can see that this is a very extremely narrow jaw here. But why wait for it and wait and wait? Because a lot of the orthodontists, they'll say, a specialist, that, oh, we'll watch and wait till they're 12, 13, 14, when their adult teeth come in, and then we'll take stuff out, remove teeth. But now that jaw has been underdeveloped for so long. So why not develop it while they're younger? So for example, you'll see young kids like this with a big overbite, but you'll see that in adults where when they're biting and the lower jaw is back. So when that adult was like this, as a teen or a little kid, they were like this too, where the lower jaw was back. So why not treat it when they're younger, to be able to sort of negate it and use their growth? This kid's jaw was back almost a good 11, 12 millimeters. So jaw pain, headaches, popping, clicking. But you can see from before and afters, the bite turned out very nice. And this is without any braces, but we were able to redirect the growth for the child at this point, right? Even in teens, you'll see facial changes too. And I'm not saying that I'm doing non-plastic facial surgery. I'm not doing that. But what I'm saying is that how the jaw fits as Lego pieces, because you have different pieces of the skull and all the bones lock into each other in the skull. But the premaxilla is the keystone for the whole skull. So all the other bones lock around it. So if there's a distortion in the maxilla, there can be distortion in the skull. So the osteopaths know this pretty well, where you'll see, like, the ears are off, the eyes are off. So, and if you look at it from a dental perspective, like, look, when we start changing and developing and expanding the jaw, you can start seeing that there's changes in the face also. So even this is another case, same thing, typical case, but this case you'd want to take out teeth, bicuspid extraction cases. But same thing, why not develop it and get the jaw bigger without having to take teeth out when they're younger? So that same thing, trapping the lower jaw back, compressing the TMJ joints. If you can expand the upper jaw, it's kind of like a shoe, and your lower jaw is a foot. So I explain to patients, your shoe right now is a size 5, but your foot's a 7. So right now your shoe is too small to let your foot fit properly. So every time you're wearing a pair of shoes that are small, your toes get jammed in there. Just like the jaw, when you're biting together, if the upper jaw is too small, it's jamming the lower jaw, which is your foot. So let's make the shoe bigger to make the foot fit better. And then you could do this in little kids, and you could do it in teens, but also you can do this in adults also. So this is an adult
Now that I
case.
took my braces off, I finally have the smile that I thought about and wanted for so long. I can't believe how much my smile has changed for the better. I'm very, very happy. Thank you, Dr. Rick.
So this is another TMJ case patient of ours. Same thing. You can see there's a big difference. But same thing. You can see how here, very underdeveloped. Everything's locked back. So the shoe. So when you're treating TMJ patients also, or craniofacial pain patients, you want to look at the mouth also. Get them to smile to see, is it trapped inside? Is the lower jaw trapped? So the thing is that from a structural perspective, something may have to be corrected, not just only neurological. So that's why these patients respond really well when we combine this together in terms of treating the jaw development and getting the alignment good for the jaw itself, but also for the acupuncture that you're using around the head and neck area to neurologically calm it down. This is another patient, same thing, jaw pain, but the jaw was off. We did acupuncture with them, but we're able to make some really cool changes where you can actually develop the jaw and make it bigger and wider to be able to provide more relief. I have a couple minutes. I'm going to see if I can just share one more thing with you guys if I can. Give me 1 second. Just want to share this one more thing here, guys. I appreciate your guys' patience. Thank you. Okay, so with this case, I'm actually going to go through the video. I have a little bit of time. I wanted to share this with you. So what it is that when the lady initially came in, the patient of ours, right, you could see she has trouble walking. But what we did was that you could see also when we're looking at it from a facial perspective, the cranial bones are off. So you can see how the ears are off a little bit, which means that the actual whole cranium is slightly off. What we can do is do cranial osteopathy and actually start leveling the skull out. And then that allows us to level the ears out, which is the temporal bone. And the temporal bone houses the articular eminence, which the TMJ condyles sit. So now you can see that when we do that, there is a difference between the right and left, that how the ears, they start leveling out. Once they've leveled out, then we can take molds of the patient and be able to construct the appliance so that it allows us to hold that change in the actual appliance itself. So from here, you can see this is from the acupuncture point. These are the points that we used for her. You can see in the middle video here, I'm going to show this here. So now when I take out the needle out of the temporal bone, so I'm going to pause this here for a second, pause this here for a second. So when I take the needles out and I take them out of the temporal, off the temporalis, I take them out, watch what happens. She completely destabilizes, right? And for some reason, the trigeminal nerve itself is having a big impact on her balance, which is through probably the pontomedullary locomotor strip that it's having an effect on, right? And then what you can see is that after we sort of figure out the points with the needles, which is here in this video on the left, we were able to use acupuncture stickers that Syrian produces, and then we're able to put them in so the patient can leave with them. So now you can see this is right after the treatment, and we used sort of the needles to kind of figure out where we need to place them. And then now you can see that she's actually standing. And she's able to turn, and she's not using a cane. Okay. And then now she's able to walk forward, and she's not using a cane. And before you saw how in the first video, she's like leaned over almost, falling over. So you can see here in the left here, we have, on the left side here, we have the actual appliance in the mouth, right? And then that's right here in the photo here, and we make the adjustments, right? And then from there, it's holding the cranial sutures better. Then also here you see in the middle, and then also there's the splint that we made for her for the bottom jaw, that now she can wear that, and that helps stabilizes her TMJ joint. So from a structural perspective, it's helping stabilize the joint. And then once we've done that, we're using the acupuncture, the neural part of it, the neurological part, and now we're able to help try to stabilize her here. Also, part of it is the vision. So you can see that when I take this, even with the stickers on, and I take the glasses off with her eyes open, she's all of a sudden the light is too much stimulation that it causes her to go off balance. So even the optic of what the light is inputting in. So sometimes you'll have to work with an optometrist that does vision therapy. So you need help from them also. This is where it's a true multidisciplinary approach that you need to work on. So you can see how the light itself affects it. And then now you can see here. And thank you.
Thanks very much, Dr. Rick.
No problem.
You have some very detailed videos.
Yeah, I document a lot. Because some of this stuff, if you tell patients or you tell other doctors or other clinicians that, hey, like we're doing this and we're seeing this, they're not going to believe you, right? So the thing is I document a lot to make sure that I'm able to share stuff like this, because then now like it's the videos are there and I have tons and tons of these, like tons and tons of, so that it's not just one patient, it's just patient after patient after patient after patient. So to make sure that at least then we can be able to teach other clinicians to be able to help people and get their life back. Like that lady that I showed you, she was like that for 5 years. She couldn't walk for 5 years. She was tilted on a slant for 5 years. She's a mother of 2 small kids. She has, in 5 years, she suffered like this. And after I started treating her, she started walking better and feeling better, being able to go out. First time in 5 years, she went out for Mother's Day with her kids. She's been in the last 6 months to a year now. She went on 4 or 5 trips on an airplane ride.
Wow.
Yeah. So like, I mean, you're literally able to give some people their life back. So it's amazing to be able to do this. And I want to make sure I can share this so that other clinicians can have that insight to be able to be like, okay, how do we do this? How do we help patients out? And how do we, get their life back?
So as a dentist, how would she have found you?
She found me through Google. So she was Googling like TMJ and walking disorders. And like I said,
Ah,
I don't treat walking disorders. I don't, as a
right.
dentist, because the neurologists don't treat it, right? The movement disorders, either they medicate it or they try to do surgery, like deep brain stimulation, like they'll do surgeries, but there's no treatment, right? So as a dentist, I'm not saying I'm treating it. What I'm saying is that there are comorbid conditions, right? Like you can have 2 different conditions at the same time, but sometimes it's pretty common to have that. Like patients with, for example, with Tourette's, they'll have neck tics and neck pain, for example, but they'll also have a TMJ problem too, because they'll have tics in the mouth. So they always do. So the thing is that if I treat the jaw and basically as a good side effect, the neck gets better, then great. Or with a gait disorder where they have upper lower back pain, but they also have a TMJ issue. If I'm treating the jaw, I'm treating to the joint, and I grade a good side effect. That's so, because the thing is that I can't say that I'm treating it, but sometimes you get a good side effect, but it's pretty consistent.
Right. That's amazing. Are there any questions for Dr. Rick? What is the mechanism of TMD crepitus or clicking?
Okay, here I can show you guys. Sorry, like I said, I didn't have a lot. Like there's a lot I crammed in, so a lot. So this I could have spoke, like I was actually in South Africa this summer and I spoke for about a day. I had a day and a half lecture and I still didn't have enough time. And so, I mean, it's been very fortunate to be able to share my knowledge, but let me pull up that lecture for a second. I'll show you guys what that component is. I'll show you guys that. I just didn't have enough time to go. I rushed through a lot of it, but what we can do is we can kind of go through that here.
It's great to have people live to be able to ask the questions, and
Yeah,
then
of
we can
course.
get a little bit more specific.
Of course. Give me one second. Okay, so what happens is when you're looking at a normal joint, this let's do this. this is the slope of bone for the upper jaw, right? That's the temporal bone. The condyle sits right here. Okay? The disc is right here in between. So basically it acts like a cushion. So what it does is that when you're opening and closing, it basically rides on the disc. So basically this disc is kind of like a toboggan. So it protects this bone down here rubbing on the bone above. Okay, and that's normal. Now, what happens is the next step from that, typically what you'll see, and it doesn't always progress this way, but the next thing you'll end up seeing is the actual joint in the disc, and the disc gets out of place. So now you can see that here, that the disc is popping in and out of place. Do you guys see that there? Right, so it's basically you're looking at this. So there's the joint, there's the bone, but then here's the disc right here. And you still, remember I was talking about how the disc has ligaments around it. So those ligaments kind of get pulled and stretched forward. So your joint is here, the bone is up here, all of this, but that it's riding on the ligaments now. So this here is your normal joint there, but then the ligaments are back here. So they're protected here and here. They're protected. The next step is, and this is where you're going to get the clicking. So this is where you get a clicking joint. Now the crepitus comes in is when you're getting bone on bone. So then that's sort of the next step. So that's sort of the next progression of moving forward, is that you end up getting bone on, sorry, you get the disc slip forward, but the disc doesn't want to go back in place. So then what happens is, here's the bone, but you can see how the bone here, this slope compared to the slope back here, compared to this slope, it gets flatter and flatter. So this is the slope of bone up here like this. It's kind of like an S shape. Here you still have that slope of bone like this, but here you're starting to see how it flattens out now. So now you're starting to get bone changes also. But what happens is that joint is right here, but then the disc is stuck out here, and then the ligaments have completely flattened, but the ligaments here now that go back are a lot thinner. And you're still riding it, but now when you're opening and closing, there are muscles from outside, like your masseter muscles and the medial pterygoid, that pull on the joint. So the joint is getting pulled upwards and squeezing that joint into the upper jaw bone also. The next step after that, in this point, you're not going to hear any noises. So the noises kind of stop. So you typically will have a patient, they come in, they're like, well, as a teenager, I had popping and clicking. So I had popping and clicking. And then when I became an adult, or later on, my late teens, it stopped clicking. So what happened is it went from the disc going back on and off to it getting stuck now out of place. So then this is what you have here now. So the disc is getting stuck out of place. Okay, so you have no noise. So the next stage from that is going to be that it's bone on bone. That bone on bone is the crepitus sound. So that's when you have arthritic changes. So now that part, when you're looking at it, is this. So this is bone. And see how it's flattened out? There's bone here, but there's no ligament in there, nothing. So it's kind of out in here and out in here, like hamburger meat, but it's literally bone on bone. And that's when you get the crepitus sound. Does that make sense?
Yes, it's very clear.
Okay.
These are great internal videos.
No. Any other questions?
What is the success rate of TMD surgery?
It's not good. It's not good. So, sir, yeah. So usually it's the last resort. Typically, I never refer a patient for surgery because usually most of those patients are worse off afterwards. There's only one surgeon in the world that I refer to is Dr. Wolford, and he's down in the US. So he's the best of the best in the world. But so if you're going to require surgery or want to go down that route, then I would say that's the person you would see. But usually most of the patients long-term wise are not any better off. And even the oral surgeons don't like doing those surgeries either. Because the fact that a lot of those patients, because they're already neurologically sensitive, they're already in pain, they're already neurologically hypersensitized, right? So neurologically sensitized. And now you're cutting all these blood vessels and nerves and endings and all, you're cutting all of that. And now you're cutting away bone, for example, to do like a joint replacement, for example. Like those people, if you're already neurologically reactive, that's not something you want to go in lightly to go in and say, I want to do surgery.
So how do you treat crepitus?
The crepitus part of it is that typically we try to neurologically to get it and functionally get the joint in a better position. So what happens is that you have to look at it as it's a process. It's not like a countertop, for example. Like if you have a marble countertop and then you drop something heavy on it and it broke. Like in that instant, you had a problem. The joint itself, like I showed you those 4 videos, it's progressive. So it's not that like you had a normal joint and all of a sudden it's bone on bone. Like it didn't go from green to red. It doesn't happen that way. Right? Typically it happens over time. And that's why I'm saying try to catch it when they're younger. Try to catch it when they're little kids. You know, even when they're born, if they have a tongue tie, lip tie, they're not latching properly, they can't breastfeed. That's where you want to start. Right? And then so what happens is typically the typical sequence you'll see is that you'll see kids around age 5, 6, 7, 8 with headaches, and they complain of headaches. And usually that and around age 6 and after. And so there's MRI studies that show that Dr. Anna Isberg did a study, and she's a world-renowned dental radiologist, and they had MRIs for skull for babies, right, from zero to 6 years old, and they had MRIs done of the head because it was from some sort of tumor cancer, like they had to do surgeries. But after they looked at those slices from day 0 to 6 years, none of them had a disc displacement, none of them had a joint problem. But at age 6, what actually happens is your first molars lock in. That's when your first adult teeth come in, and that locks your bite. Right? And then so now age 7, 8, 9, a couple of years later, if the jaw's narrow because you're mouth breathing, like, you know, or you have a tongue thrust or thumb sucking habit, and the jaw didn't grow long enough, or the upper jaw, your shoe wasn't big enough, it trapped your foot inside of it. You're still gonna grow, but it's distorted. Right? So around 6, 7 years old, 8 years old, you'll have headaches type situations, headachy, even like sensitivity to sound. You'll also see a lot of airway issues in that age. Bedwetting, sleep talking, sleepwalking, hyperactivity, because the thing is that the jaw is narrow, the tonsils and adenoids are large possibly, so they're not breathing properly. So an airway problem or snoring in kids is not normal. Kids shouldn't snore. So the thing is that it's a long answer to this, but what it is that those tonsils and adenoids at that age need to be looked at, right? So then they treat the jaw, expand the jaw when they're younger. And as they get older and older, what happens is that if you don't do that now at a young age, now they're in their teens. And typically what happens is 50 to 90% of pre-orthodontic kids have a joint problem or a TMJ problem. It's in the orthodontic literature. But a lot of the times it's not taken as seriously as it could be. And then so what happens is these teens are treated and they get braces done. And then what happens is that they're like, oh, when I had braces, I have click. We all see patients like this, right? So then all of a sudden, as a teen, they're like, yeah, I used to get click, 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 click as a teen. I had braces and it maybe got worse, maybe better. It locked a little bit and it got stuck. I couldn't wiggle it out. And then afterwards, braces came off and it wasn't really a problem, but I still clicked. But then maybe I got my wisdom teeth out when I was 18, 19. And after that, my jaw flared up and then I was locking more. And then after that, then they're like, well, then I kind of got over it. Then, or some of them are still acute, and then I end up seeing them at that age. Or now they're in their mid 20s and 30s. They're like, well, I'll see them when they're 25, 30 years old. And they're like, oh, yeah. And then they'll say, yeah, when I was younger, I used to have headaches. Or when I had braces and as a teenager, I had clicking before braces. And I had my wisdom teeth out. It made it a little bit worse. Then it kind of got better. And now in my 20s, like I'm getting more headaches, migraines, typically females, right? And then from that perspective, they're like, well, I'm getting jaw pain where I'm having trouble chewing and biting. I still get clicking. And then some of them will also say, yeah, I used to get clicking when I was younger as a teenager, but now it's stopped. So then that's where the yellow screen I showed you where it clicks in and in. So it goes from yellow to red. Now it's stuck. So now you're in your 20s and 30s, the disc is stuck now. And then now you have headaches, migraines, neck pain. The jaw may stop hurting now too. So now these patients in their mid 30s, 40s, 45s, they're coming in. They're like, well, I'm having trouble opening, but I've seen 15, 20 people already, and I'm having jaw pain, headache, migraines, shoulder pain, so on and so forth. But I'm like, look, I'll look at it from a joint perspective. I'm not a neurologist or a chiro or an ENT or an orthopedics. I'm not doing what they do, but let me look at the jaw. And when you start taking MRIs of these jaws, and I have over 700 MRIs, TMJ MRIs of patients. So the thing is now when they're in their 30s and 40s, you start seeing this stuff. That's where it's sort of a progression. That's what happens. So these are symptoms as you see as they get older. It's something that was there right from the beginning of maybe age 6, 7, 8 potentially, and it can progress all the way up until your late 30s and 40s, but you see sort of a sequence of these events, and that's a typical sequence that you'll see.
So I know as a dentist, we have a question from a chiro perspective.
Yep.
What can you do with an erosion of the TMJ disc?
The erosion of it. So what it is that crepitus part. So now let's say they got to the crepitus point, right?
Hmm.
So now from a joint perspective is that what you want to do is that you can't fix the joint in terms of getting, like I said, it's not like a broken table. You broke a table, the marble table, you could buy a new one. You completely replace it. You can never get back a normal joint. But what you want to do is you want to get rid of the overloading of the biomechanical overload, number one, right? Which means that the entrapment of the upper and lower jaw, how they align together. So the thing is that some of those patients you can use is a certain type of oral appliance that they wear at nighttime to protect the joint as best as possible, so it doesn't get any worse. So what I was saying is that like sometimes you have an acute phase where things hurt and then it goes away. So that crepitus didn't start or the joint erosion didn't start in your 50s. It's been a progression, but what happens is throughout your teens, it kind of flared up and it got better. Then in your mid 20s, it flared up and then it got better. Then your 30s, it flares up and gets better. So sometimes you get these waves. So you have a chronic problem all along, but you get these spikes of acute phases. So then that's when they come in where like I have crepitus in my joint, but now they're having debilitating headaches and migraines. So acupuncture works well for that in terms of certain points that you can work on. One. Number two, an oral appliance works really well too for those patients also. So that you can combine the neurofunctional acupuncture along with oral appliance. And that works well for a lot of the patients. Also, what happens is not only here, but you can look at the trigger points of the neck and the trapezius and the SCM, and you could do trapezius and neck work and do dry needling if you're comfortable doing trigger point needling, right? Or you do it from a acupuncture perspective, but that works really well too for those type of patients.
Right. I know that sorry, one more question. What is the
Yeah, of course.
TMJ disc made of?
It's basically like a cartilage material. That's why it's like fibrocartilage, right? So it's a little bit different than the other parts of the joints that we have, but that's in essence basically it's a fibrocartilage that you're looking at.
I know that you've had to kind of rush through a lot. You have a lot of material. I really wanted to give you an opportunity to talk about the upcoming course for the people that are interested, because there might be a lot of people that have more questions that can get really into more specific things in your
Yeah.
course. So
Yep.
we've got one more question,
Sure.
and then maybe we'll stop the recording and we'll give you a chance to talk about
Sure.
what
Sure.
people
No
might
problem.
expect or be able to find out more
Sure.
information.
Sure. No problem.
Is it possible to acupuncture direct to joint, or is that bad?
I usually I don't needle the joint, the capsule itself. The reason is highly innervated by basically a plexus of the auricular temporal nerve, the masseteric and deep temporal nerve. Basically 360 degrees, you have all these nerves. So if the patient around the joint. So if you're looking at the joint itself, you have all these nerve endings. So it looks like, so around that TMJ joint here, when you're looking at it, 360 degrees around it, you have all these blood vessels and nerve endings that basically literally surround. So if you're needling that capsule, you're going to be hitting, one is the blood vessels. Also, can you see that now? Is that better? Can you see somebody messes? I can't see that. So basically around that joint, if you're going to be needling around it, it's going to be from the lateral aspect of it. She said no.
Oh,
Can you see that right now though, dear? Can you guys?
can you see it?
The video, you can see me in the video, right?
Yes.
Okay, so then you should be able to see me. So when you're needling the joint or the capsule, you have blood vessels, one that surround it 360, the sympathetic fibers that carry on it, and also the actual you're actually seeing the nerves that go to it. So if you're needling something that's already hypersensitive, you don't want to be needling the capsule in any way, shape, or form, because it's very neurologically reactive. So that the capsule you want to avoid as much as possible.
I hope if you didn't see his video, or if your video has frozen, I'm hoping that this is taping and you'll be able to watch that answer back. All
Or
right.
you can even send me a message, like my email contact. You're more than happy to contact me. We can walk through it again.